touching on a few things that have probably changed the landscape of COPD in recent years. You all know this quite well, and we keep getting bombarded by it, but I think it does point out to the fact that COPD is going to be around much more often and much more forcefully in the coming years, because everybody's sensing how bad the problem is, and especially because the exposure that we have to all the noxious particles, especially smoking, does not seem to be finding any way out. I will dissect in a minute or two the definition from the latest gold document strategy that came out in late 2011, where it actually for the first time, I think, was quite comprehensive and shed important light on the different facets of COPD as a condition. What was very I guess to me reassuring and made me hopeful for the future is that for the first time we're talking about a preventable and treatable disease, which is something that was not the case only a few years ago. It is characterized by persistent airflow limitation that is usually progressive, and usually it is secondary to an attack by noxious particles or gases, smoking being on the top. It's a chronic inflammatory condition, and that is quite pointed out clearly in the definition, and it leads to the probably plethora of symptoms that the patient with COPD will present. What was also quite interesting and important, I think, is that for the first time it was put in its context as a condition that affects the well-being of patients from all different angles, and that's why the exacerbations, their importance, and the comorbidities and how they affect and are affected by COPD contribute to the overall severity in individual patients. The prevalence of COPD varies from country to country, but I guess it is safe to say that it is one of the most prevalent conditions in the aging population, especially in countries where smoking is prevalent, and it is an underdiagnosed condition, and that's another challenge that is put in front of us as clinicians to try to make a better way of making the diagnosis, making it in a timely manner, making it as early as possible to implement proper interventions. This is actually important because from the BOLD study it was found that it was undetected in about half the cases and misdiagnosed in about the quarter of those cases. What is also very important, I think, that should be pointed out again during our discussion of COPD is the fact that now spirometry is required. We have to have a spirometry to diagnose COPD. So you cannot have a proper diagnosis of COPD unless a spirometry that fit the criteria as they are outlaid by the GOLD strategy document are made. The symptoms, that's what patients come to us for. Breathlessness, dyspnea essentially, cough, wheezing, chest tightness, sputum production, and their impact on well-being is quite tremendous from everything they do. And this is because of the damage that occurs both in the pulmonary parenchyma as well as in the airways, leading to what we know about COPD. You've seen this spiral before, and it is quite self-explanatory. There is a similar spiral that I think can be probably appreciated from the patient standpoint, and that's the one I think we're going to be focusing on, and Dr. B is going to be shedding additional lights upon. It is the dyspnea inactivity downward spiral, which is extremely important because that's what's going to define how the patient is going to feel and what he or she are going to do in an everyday life. And the worse that feeling is of dyspnea, the worse the patient's quality of life is going to be, and the more complications and comorbidities we're going to be dealing with. And that's because, of course, in big part due to the pathophysiology of COPD, including the importance of hyperinflation and the increase in both physiologic and anatomic dead spaces. Issues in the GOLD document 2001, I will not go over them, but I will just point out that working on dyspnea and hyperinflation is key to making patients better. This was noted quite clearly because bronchodilators are a cornerstone of all the different treatments in all different subgroups of the GOLD classifications, be it group A, B, C, and therefore they are the cornerstone of pharmacologic management. And these will lead to the goals that the COPD patients wish us to help them achieve, and that is to improve their quality of life and, of course, improve their mortality. With that, please help me welcome Professor B. He is quite known to you by now. He is the author of more than 100 peer-reviewed articles in the best-renowned journals, including the New England Journal of Medicine, and he is a reviewer of the most prominent journals, including the Blue Journal. Professor B.
Thank you. First of all, thank you, a warm thank you for your very kind introduction. Thank you very much. You have perfectly set the stage for my talk, actually. I recognize a lot of faces from my talk yesterday, so obviously I didn't totally scare you away yesterday, so that really honors me. So you managed not only to follow one of my talks for once, but you also came back actually to listen to me twice, so that is really a big honor for me. Thank you very much. As you have already been introduced, it's my great pleasure now to show you some of the current approaches to treatment in COPD. The armamentarium we already have at hand today, but as you are a very specialist and a highly sophisticated audience, I would also like to point out maybe into some future directions, show you some of the very new and very emerging data that we have for treatment of COPD. And of course, we have to look, if we're looking at current treatment options in COPD, we have to have a look from actually where we're coming from. I appreciate that probably most of you will know this lady. She's quite famous in my country. Actually, as you can see, she has had a major influence about our traditional thinking of COPD. Because what she's actually telling you is, if you dilate, you cannot dilate, it's irreversible. You can't get more than this. So as she's a very influential researcher, we believed this for more than 20 years. We thought COPD is an irreversible disease, but actually we proved the lady wrong. We know now that COPD is not irreversible, and there has been dramatic progress in improving bronchodilation in COPD, and finally and ultimately, which is very important, improving outcomes in patients with COPD. Now, we've already heard that there's been some workup in the GOLD classification. We're now shifting from a bi-yearly or a triennial workup. We're shifting to a yearly workup. Things are evolving fast. Probably in future times, it's all going to be web-based, and maybe we'll have a daily update on GOLD. However, 2013 is the latest update. It's not a fundamental difference to 2011. I think the basic shift in paradigm was in 2011. Whether from an educational perspective this new categorizing system is something that is very appealing, I have my doubt. I have some problems in explaining that, particularly to family physicians, primary care physicians. I think it's a bit complicated. Anyway, if you break it down to what the essential message of that is basically we're not only categorizing according to spirometry, well, that's fine, but now we are stratifying according to symptom load and exacerbation. And this is also the main target for treatment is, of course, target symptoms and the whole complex that goes along with symptoms, and then target future risk, where future risk is defined with exacerbation. I have my personal view on that. I would say that exacerbation is definitely a major defining factor for future risk, but I would also like to point out in my talk that I think that impairment of physical activity is probably the most important or the central factor that defines future risk for a patient with COPD, and I'll show you some evidence for that. Now, this is what we have. We have these categories A, B, C, D, and the only thing that I think you will agree with me is essentially, I think you can forget about A. I mean, A is a category with near normal lung function, no symptoms, and no exacerbation. So my question is, why should a patient with COPD category A go to a doctor? I mean, I don't see these patients. I don't know whether you see these patients. they're in there, but I think for the clinical practice, they're basically meaningless. Unfortunately, COPD patients go to a doctor if they have symptoms, so they're at least B or D, or maybe if they have an exacerbation. But then again, I think the separation is very artificial. If you consider that the definition of an exacerbation includes an increase in symptoms, so that means by definition, if you have an exacerbation, you have symptoms. I mean, that's it. So this is a bit artificial. It's a bit, well, it says, it suggests that there's a clear separation between exacerbation and symptoms, which is not the case. And it also suggests that this is a static system. Again, it's not true. It's not if you're once in category D, you stay there forever. And even if you have patients that are exacerbation-free for a period of time, they may have one or two exacerbations the next year. So it's not a static system, and this is why I have a bit of a problems with this staging system, and particularly the perception and the communication of this staging system. And also the recommendations for pharmacological therapy, although I acknowledge, I mean, the view has to be balanced. It's a global organization, and they are becoming increasingly politically correct. So they have to take into account every place in the world where there may not be all treatments available. However, I think it's a bit non-specific, what they call a recommendation. I can't really get a recommendation out of that. I mean, what you can see, as I said, forget about A. What is in fact fundamentally different from asthma is that in all categories that are relevant in COPD, B, C, and D, you will find an option, a choice, where you can do proper treatment of COPD without the use of inhaled corticosteroids. So that's one of the basic messages. ICS are in C and D. There's one option, but there's no indication that the use of ICS is in terms of improving any outcome parameter better. In fact, for most of them, it's inferior. I will show you. Then optimizing bronchodilation in patients with COPD. So anyway, however confusing that may be, it's clear, and you've already heard from our chairman, that bronchodilators are and will be the cornerstone of treatment of COPD because they have a variety of beneficial effects on defined, well-defined outcome markers in COPD. And of course, the reason why we shifted from short-acting to longer-acting twice daily and then to once daily drug is, of course, very nicely illustrated in this concept, the concept of pharmacological stenting, opening up the airways, providing true trough morning FEV1 over 24 hours, and thus consecutively improving symptomatic and patient-reported outcomes in COPD. And this concept, and I like to show this study again, is very nicely been proven. In fact, it's one of the only studies that we have, clear studies comparing once versus twice daily bronchodilation, and it's clear that the once daily bronchodilator not only provides better bronchodilation in terms of improvement in trough FEV1, in this case Indacaterol once daily versus salmeterol twice daily, a very clear scientific clear comparison, the principle of once daily versus principle of twice daily, same class of action, beta agonist versus beta agonist, very clear result, substantial improvement in lung function with once daily versus twice daily, and as I have shown in many of my earlier talks, not only there was an improvement in lung function, but that also went along with a significant improvement in dyspnea and quality of life on those patients who were on once daily versus twice daily. So there's clear proof of concept. And because there is clear proof of concept, it's not very surprising. If you look at the pipeline of many of the major pharmaceutical companies, you will find that there is a strong dominance in the development program of bronchodilators, mainly long-acting, either beta agonists or anti-muscarinics or fixed combination of both. And basically the only drug that is a bit outstanding here, there is a one combination of once-daily LABA ICS, vilanterol fluticasone, furoate, which is a once-daily modification of fluticasone. I'll show you some data of that because the data are rather mixed. So this really illustrates the question, or opens up the question, what is the best strategy in the future? The first strategy, is it to optimize bronchodilation, to maximize bronchodilation, or is it to add inhaled corticosteroids? And I have some evidence for that. Now, this is what I would like to discuss in my talk. I mean, as we have agreed that bronchodilators are important, the question is, in fact, are there differences in outcomes between the different drugs that we have? I've already shown you the comparison of Indacaterol once daily versus salmeterol twice daily. I show you maybe touch some of the differences on LABA versus LAMA. And then I discuss with you, which is something that is very important in your everyday clinical practice. If your patient may be not well controlled or satisfied with one treatment, one bronchodilator, what is the best add-on strategy? Is it better, if you have a certain patient, to add an inhaled corticosteroid, or is it better to combine bronchodilators? And we look at some of the outcomes, some of the evidence we already have, and some of the evidence that is emerging, and that will definitely influence our thinking about COPD treatment in the near future. Now, this is one of the studies that directly compared a once-daily drug, a once-daily long-acting beta agonist, Indacaterol, and a once-daily long-acting muscarinic antagonist, tiotropium. It's a very nice study, parallel group, no placebo here. It just compared once-daily versus once-daily over 12 weeks. And it had some very interesting messages. And one of the main messages that we learned here is that Indacaterol and tiotropium, in terms of improvement of trough FEV1, after 3 months of treatment, were equally effective. Both provided significant bronchodilation versus baseline, and the magnitude, you can see that basically there was no difference here. And also the change from baseline, well, 10 ml difference. Clearly, there was non-inferiority, so both drugs are comparable in terms of improvement of trough FEV1. However, if you look at patient-reported outcomes, then you see that there is a clear difference between the drug. In this study, we saw there was a substantial larger proportion of patients that achieved a meaningful improvement in their dyspnea, and also those patients that improved to a meaningful extent in their quality of life. The proportion was much larger with Indacaterol versus tiotropium. So despite similar effects on trough FEV1, we had dramatic differences in patient-reported outcomes. So it again illustrates and teaches us something about the view that we have on COPD. So we only correlate many of the outcomes with trough FEV1. Maybe we should look at other lung function parameters to understand why this is the case, because we don't really have an explanation for that. The most likely explanation for that is probably that Indacaterol has a very fast onset of action. And that's what my patients report to me, they love the fast onset of action. That's why, for example, they love every treatment that contained formoterol, because it goes a very fast onset of action. And if you get up in the morning and you are grasping for air and you really have difficulties in breathing, then of course you don't want to wait for your bronchodilator to work. And we know that with tiotropium this may take 30 minutes, 45 minutes, 1 hour, sometimes even longer to reach a peak effect, whereas with Indacaterol you get this within 5 minutes. And although on trough and steady state this may be not relevant, but this may be relevant for the patient. The first impression he gets in the morning, it's really, I've got acute relief of dyspnea. So obviously, pharmacological differences between classes of drugs and between drugs may have important impact on patient-reported outcome, although in terms of lung function improvement, they may have comparable effect. Now, what about the comparison of a once-daily Indacaterol versus ICS LABA combination? I think, although I like to cite INLIGHT study very much, the comparison to salmeterol, because it proves something scientifically, of course, I acknowledge that treatment reality is usually not to use salmeterol monotherapy. So you would say, well, if I use salmeterol, it's usually in a fixed combination. So what about the effect of Indacaterol monotherapy versus fixed dose ICS and LABA? But there's no direct comparison of these drugs. However, there is a lot of data in the literature, and there was a network meta-analysis recently been published where they gathered all the data, the efficacy data, on Indacaterol in a comparable population of COPD, comparable duration of treatment, and compared that to the effects that have been reported for ICS-LABA combinations Symbicort and Seretide, actually. Now, what you see is here, this is the effect of Indacaterol versus placebo. Forget about that. We know that it's better than placebo. Now, this is interesting. This is the reported efficacy values in trough FEV1 of Indacaterol if you compare that to what has been reported in the literature for Symbicort, low dose or high dose. And you can see that on every level and every study that has been reported, obviously, there seems to be a difference in favor of Indacaterol. So by an indirect comparison, you can guess, well, okay, you may say it's not a direct comparison, maybe it's not scientifically valid. However, I take it like that. I would say it's at least as good as twice-daily Symbicort with 2 drugs if you use Indacaterol monotherapy without steroid, 1 drug. And the same is true for Seretide. All the studies show a trend in favor of Indacaterol, but as I said, it's an indirect comparison. I wouldn't overvalue this network meta-analysis, but it really gives you an idea that if you want to improve lung function, obviously, well, Indacaterol versus ICS LABA combination is obviously not really a bad choice. I would leave it like that. Now, you may be interested and say, okay, what about if we add an inhaled corticosteroid to an already very effective once-daily long-acting bronchodilator? Can we further improve lung function? Now, this is some very interesting data, very recently been published, April 2013, just been online, because this is one of the first studies, longer-term studies, reported in the public domain for the ICS LABA once-daily development of GSK, which is called BRIO, which is a combination of fluticasone, furoate once daily, and vilanterol, which is their once daily long-acting beta agonist. And they did a study over 6 months where they compared the combination with the fixed combination of long-acting ICS and LABA with the long-acting LABA alone. And you can see that they gathered actually very mixed results here. This is lung function and symptom improvement. And what's important is here, you can see that the addition of fluticasone to vilanterol actually did not affect the primary outcome, weighted mean FEV1. It did not affect the trough FEV1, and it also did not further improve dyspnea score. So obviously adding an ICS to a very effective once-daily long-acting bronchodilator is not truly a very appropriate strategy when it comes to lung function improvement or symptomatic improvement. In contrast, if you compare this to the strategy of further trying to improve bronchodilation, you get totally different results. Now, this is an example, for combining Indacaterol with tiotropium, so a LAMA-LABA-free combination. The INTRUST study, actually these were 2 studies, one in the United States, one in Europe. Actually, they showed they have the same message, they have the same outcome. They show that if you add Indacaterol to tiotropium and compare this to tiotropium alone, you see that you get in trough FEV1 improvements of additional 70 to 80 mils by adding Indacaterol to tiotropium versus tiotropium alone. Now, we all know that tiotropium alone is already very effective, and Indacaterol alone is at least as effective, and if you combine these together, you get additional 80 mil improvement in trough FEV1. Just remember, the MCID, the minimal clinically important difference in trough FEV1 versus placebo is believed to be in a magnitude of 100 ml. And this is actually two active drugs versus one active drug, and that approaches the MCID versus placebo. So this is really a meaningful result in terms of lung function improvement. So there's no doubt if you want to further improve lung function, the strategy should be to optimize bronchodilation and not to add an inhaled corticosteroid. Now, what about symptoms? You may not be interested in lung function because that's not necessarily what matters in COPD, whereas symptoms do matter. And again, we do have data. We do have data in symptomatic patients. Now, this is a comparison, also a very new study just been published in Lancet Pulmonary Medicine. This is a comparison of ICS LABA twice daily compared to a once daily combination of Indacaterol glycopyrronium, which is called investigational QVA149. It's a once-daily LAMA-LABA fixed-dose combination, and this was tested in symptomatic patients with COPD, and the outcomes was symptom. Now, this is lung function, and you can see that, of course, as I told you before, if you combine 2 bronchodilators, you get much better effect on lung function. That's not very surprising. However, if you look at dyspnea score, you see that there were also dramatic differences, the combination of bronchodilators versus ICS LABA. So again, illustrating that if you want to impact on symptoms and lung function, the strategy is, if you don't get along with one drug, once daily bronchodilator, the strategy is to add a second bronchodilator, and the strategy is not to add an inhaled corticosteroid. Now, you may say, well, ICS are not basically, we know that, it's not very good at improving symptoms. However, symptoms is very important in COPD. So in terms of one of the main targets for treatment, we know that this type of drug is already not very effective. Okay, take it that way. They are indicated for patients who have a history of repeated exacerbation. And it's very intuitive in a way to think that exacerbation have got something to do with inflammation, because it sounds very similar. However, we know that, although we know that during an exacerbation there is an increase in inflammation, there is no definite proof that actually the level of inflammation in a patient with COPD may trigger exacerbation. We know that patients without inflammation, they have exacerbation. And what's even more important is that we know that drugs that have absolutely no effect on inflammation, namely long-acting bronchodilators, are very effective in preventing exacerbation. Monotherapy, without anti-inflammatory drug, if you like. I have my doubts whether ICS and COPD are anti-inflammatory, but that's a different story. However, so you take long-acting beta agonists, for example, in this case, pooled analysis for Indacaterol, you get a 30% reduction in exacerbation. And I can grant you, definitely, Indacaterol has got no anti-inflammatory effect. So it's not all about inflammation. We have to acknowledge that in 50% of exacerbation, we don't even know the cause. So why should we bother about thinking whether this got something to do with inflammation or whatever? Look at the treatment, whether it's effective. And obviously, long-acting bronchodilators are very effective in preventing exacerbation. And that's something I'd like to point out. I love this story because this study is really a very nice example for that. This is a story that exactly takes this concept forward. And it asks the question, can you prevent exacerbation with an effective once-daily long-acting bronchodilator alone, or do you need an add-on of inhaled corticosteroid, in this case a combination of salmeterol fluticasone, to prevent exacerbation in the particular risk group. So this study was done in patient lung function less than 50%, history of exacerbation of at least 2 exacerbations in the year preceding to the study. So exactly those patients that we find in C and D where we have the recommendation for ICS in combination with LABA. Now this is a direct comparison, ICS LABA versus, in this case, tiotropium, LAMA alone. And what they found out is that, in fact, if you take these 2 drugs, if you compare the fixed dose and monotherapy bronchodilator, you get the same reduction in moderate to severe, so all those exacerbations that matter. These are those with steroids, antibiotics, and or hospitalization. The same effect with the bronchodilator, so you don't necessarily need inhaled corticosteroid. The bronchodilator does it. It's a nice result. It really gives proof of concept. It's not necessarily in terms of preventing exacerbation, although, of course, there is evidence for ICS and LABA to prevent exacerbation, but the question is it better to use 2 drugs twice daily than to use 1 drug once daily? Well, I have an opinion, and I have an answer to that, and I leave it up to you to answer this question. Particularly because if you treat patients with a drug, what you do every time you write a prescription, or should do, is to do an individual benefit-risk assessment. So you have to weigh whether the drug that you're actually prescribing is effective, weighing against the potential harms. There is a saying in Germany, we say basically every drug, the basic assumption, every drug is harm, unless its benefits outweigh its harm. So you really have to have proof that the benefit outweighs the harm. Now, is there potential harm in inhaled corticosteroids in COPD? Unfortunately, unlike in asthma, because we need higher doses, there is, and this is a different population, elderly patient, comorbid patient, there is an issue that is emerging now. And the main issue that I would like to talk about is pneumonia. The increased incidence of pneumonia with inhaled corticosteroids in COPD has been replicated in a series of trials. Now, while these trials have been very often heavily criticized because the workup of pneumonia was not proper and you didn't know whether these cases were true pneumonias or whatever. Now, there's clear evidence now, and this is very fresh, just taken from the internet. There is clear evidence now from the phase 3 registry program of, again, the ICS LABA, once daily ICS LABA combination, for treatment of COPD, that there is a problem with inhaled steroids, namely with fluticasone in COPD, in terms of increasing the incidence of pneumonia. This is the dossier, the submission dossier for the drug vilanterol fluticasone furoate, and you can see this is the safety table. You can see that in all arms where fluticasone furoate, the ICS, was involved in comparison to the monotherapy, you get a doubling of the incidence of pneumonias. And you can be granted that this study, since it was, of course, the program was set up by GSK, they have already been alarmed by some of the results of the other studies. You can guarantee that workup of pneumonia was definitely proper in these clinical trials. We have seen similar observations also in POET, In the POET study, it had a different approach, but anyway, if you look at those patients who were on steroids in POET versus those who were not on steroids, there was an increased incidence of pneumonia. So definitely there is an issue, and that of course affects our benefit-risk evaluation. And also something I'd like to point out, is that if you use very high doses of ICS in COPD, this is a cohort study of 400,000 patients, where they followed patients who were on very high doses of ICS 1,000 microgram, as is approved for COPD in my country, and they looked at the risk of newly diagnosed diabetes, or if they already had diabetes, progression and loss of control of diabetes. And again, there was a risk increase with the use of high-dose inhaled corticosteroids. And so taking all that together, again, you should weigh and you should balance potential benefits and risks in patients with COPD, and to really define what is the optimal strategy in targeting well-defined outcomes in patients with COPD. Because if you want to further impact on exacerbation, you say, well, I have a patient who still has exacerbations. Again, what is the strategy? Optimizing bronchodilation or adding an inhaled corticosteroid. Now, there's also some emerging data. This is a study called SPARK, and SPARK compared, again, the fixed combination of Indacaterol and glycopyrronium, so LABA-LAMA fixed dose combination, versus LAMA alone. I've just showed you 2 slides before that LAMA alone is very effective already in preventing exacerbation. And if you use a combination, fixed combination, you get a further significant reduction versus monotherapy in moderate to severe exacerbation. So again, if you want to target risk, the optimal strategy, that's what I think, what I believe, and this is why I believe the future is going to be, is to optimize and to maximize bronchodilation first. Now let's finally touch on hyperinflation, because I think hyperinflation is not necessary, it's a link between, if you like, the symptom category in COPD and the risk category, because hyperinflation actually determines the level of a patient's physical activity, and physical activity in a way determines the likelihood of overall mortality. So I would say hyperinflation really is the link between symptomatic treatment and risk targeting treatment in COPD. Now this is a situation in COPD with severe hyperinflation. The boat is full or it's nearly full. So this is, if you like, residual volume here. Patient is operating at total lung capacity and is always at risk of actually drowning from his air. Virtually he's drowning in air. That's really a nice image. If you sometimes ask patients, they will say, "Doctor, I have the feeling my chest is just full of air, but I can't breathe." It's really funny. You talk to lay people, sometimes very difficult to understand. They will say, well, it's nice, they have 10 liters of air in their lung. They should be super athletes. Well, they can't make use of these 10 liters. They can only make use of a small proportion of that. Now, what happens is, of course, that we know that if patients with COPD do exercise, there is dramatic further worsening of this hyperinflation, unlike in healthy subjects where there's a lot of respiratory reserve during exercise. If you look at MRI scans, the patient with COPD, a lot of hyperinflation at rest already. Well, and then if he exercises, actually, not a lot of improvement or even increase in the respiratory mechanics going on there. So that means dynamic hyperinflation occurs. Hyperinflation gets even worse. Well, if it wasn't written down there, probably you couldn't tell the difference, what was rest and what is actually during exercise. So there is no really, there's no capacity of these patients to actually perform exercise or to improve their performance when they need to exercise. And that is why we need to impact on that, because that means if patients experience dynamic hyperinflation, and that occurs exercise is not, they're not running a marathon or something like that. This happens during everyday, normal daily activities. So that means they have a sensation of dyspnea, and the sensation of dyspnea causes these people to avoid dyspnea, and the best way to avoid dyspnea is to avoid physical activity. And that means the more severe COPD gets, and the worse hyperinflation is, the more patients reduce their physical activity. And this is why I believe this is so important for the future risk and outcome of patients, because physical activity has a major impact, not only on COPD, but on all these very important chronic internal medicine diseases. We know that patients with COPD rarely have COPD alone. they usually have a lot of comorbidities, and these are the very famous comorbidities that they have. And physical activity beneficially impacts on all of these. We just had a recent study where it was clearly shown that physical activity is better for diabetes control than diet. Activity is better than diet for diabetes control. So clearly all of that is impacted by activity. Keeping patients active, and that may mean 10 or 15 minutes per day, will have dramatic impact on all that. And I'm convinced that if you do a proper trial, ultimately you will reduce mortality in these patients, all-cause mortality, because you keep them active. There's also some retrospective data already to illustrate that those patients who are less active in COPD, where they have a very high likelihood to be admitted to hospital, if you categorize patients according to high or moderate daily activity versus low or very low, they have an increased risk of hospital admission, and they have an increased risk of dying for whatever cause, not necessarily COPD, but for whatever cause. So getting them active is crucial and essential to our approach to treatment. And again, it's not only a disease that affects the lung, and this whole complex of physical activity limitation is something that goes beyond the border, basically, of your organ. I mean, we're taught in medical school to, in a way, specialize. We have to look at certain organ systems, and in a way, because we only deal with these organ systems, we get biased over decades. And our view is basically, well, if it's not happening in the lung, well, is it happening at all? And if you talk to cardiologists, they would say, well, basically every disease, even if you have whatever tickling in your ankle, probably has got something to do with your coronary heart, with your coronary arteries. Yeah? So you get biased in a way. But you have to keep in mind that in these patients, the organ systems interact, and this is a very beautiful study that nicely shows how this actually happens. It looks complicated at first glance, but it's a very, very simple correlation. This is dynamic hyperinflation occurring during exercise in patients with COPD, and this is cardiac output, stroke volume, measured as oxygen pulse during exercise. And you can see that the stronger the degree of dynamic hyperinflation, the lower the cardiac output during exercise. So that virtually means, mechanically speaking, if these patients pump themselves up during exercise, this pumping up of the lung will actually impair the mechanical features of the heart. To keep it very simple, it's got to do with diastolic filling and stuff like that. However, it's a very clear correlation. If you have dynamic hyperinflation, that impacts the stroke volume of your heart. Very nice. So if you impact on hyperinflation, you impact on the output and performance of your heart. So this is the reason why it is central to keep patients active. And how can we keep patients active? Well, one of the ideas, of course, if you want to reduce hyperinflation, is you can have the surgical approach, which I sometimes like very much, because they say, well, if you have a problem, get rid of it. Just take it out. So we say, if you've got hyperinflation, well, then let's operate it. We'll do some surgery. Well, it works in some patients. I mean, if you look at this is lung volume reduction surgery. Well, in the 90s, as it was emerging, we were very enthusiastic about it. Now we know it only works in certain patients. However, if you look at here, those patients who underwent lung volume reduction surgery compared to those who were not operated, this is again cardiac output during exercise. You can clearly see that those who were operated at different stages of exercise, they had an improvement in their cardiac output. So the idea of actually reducing hyperinflation, in this case by surgery, and thus improving cardiac output obviously seems to work. There's a nice idea behind that. The other way to do that is, of course, by using long-acting bronchodilators, because, as I said, pharmacological stenting not only leads to stenting of the airways, but the prolonged opening of peripheral airways also increases the likelihood that the trapped air of the lung can actually come out of the lung. And this is what we call pharmacological volume reduction. And, of course, essentially, the longer the action of bronchodilation is, the longer the peripheral bronchi are open, and the more trapped air can actually evade even during tidal breathing. And again, this has been proven in many studies that, of course, if you use long-acting bronchodilators, you get better effect on hyperinflation, and you also get an effect on dynamic hyperinflation, which is very important, as I just outlined to you. This is a study that we did in Wiesbaden, in my institute, where we put patients on a cycle ergometer, and we tried to figure out what happened during exercise. We measured dynamic hyperinflation. patient with moderate to severe COPD, and then we put them on Indacaterol, and after 2 weeks we repeated the same story again. And this is a comparison to placebo. At peak exercise, you can see that there was less dynamic hyperinflation because they had more inspiratory capacity, which is an indirect marker of hyperinflation. So they had more inspiratory capacity, less dynamic hyperinflation on day 1 already, after first dose, and the same effect was still there and present, and even in a magnitude was even more. The difference to placebo increased after 2 weeks. So that clearly shows that you can impact on dynamic hyperinflation, and that means in the end that a patient could cycle for a longer time because dynamic hyperinflation was reduced. We were able to demonstrate that those severely impaired patients were able to cycle on in this endurance test for more than 1.5 minutes longer than in comparison to not being on a long-acting bronchodilator. And that has been replicated in a similar study in Canada and United States. So there's clear evidence that if you affect dynamic hyperinflation in patients with COPD, you improve their physical capacity. However, you may say, now physical capacity is one thing. Being capable of doing something does not necessarily mean you actually do something. So the most decisive part is whether patients make use of this capacity. So the transition from improvement of physical capacity to improvements of physical activity, that's the decisive part. If you don't make use of it, it's no sense at all. So we took this a step further, and there was a different study that we did in Germany, also with Indacaterol, where we for the first time could demonstrate that patients on a long-acting bronchodilator increase their not only the physical capacity in the lab, when the doctor stands beside them and says, come on, come on, come on, come on. No, when they go at home, we could demonstrate that they increased their daily steps per day, their daily activity, and the duration of moderate daily activity was increased in comparison to the control group by nearly half an hour per day. So that was really something that was remarkable. We know from mortality studies in general population that usually 10-15 minutes of exercise or moderate activity per day can have an impact on all-cause mortality in a population. So I would say that 30 minutes in the COPD population will eventually really have an impact on their mortality. And this is why I also welcome the company, or any company, that believes in the concept of improving physical activity. They should not be scared, they should take the risk, and they should do another mortality study, properly powered, looking at the right patients. Because ultimately that's what we need. We need to show that our treatments are effective in improving mortality. Now that's basically my message for today. I think it's clear that now and in the future that bronchodilators will remain the cornerstone of therapy for COPD. We know now that the new classification, although it spreads up a bit and accounting for symptom load and future risk, not only relying on spirometry, nevertheless, I've shown you that if you target symptom load and future risk, I've shown you that bronchodilators are clearly very effective and should be the first choice. The choice of drug, which bronchodilator you should use, if you start, of course, that should be based on the clinical efficacy and maybe the patient characteristic. There also may be contraindications or whatever. And I've clearly shown you that the combined use of drugs, now in free combination and in the future in fixed combination, may have potential for further improving outcomes in these patients. And I've clearly shown you that bronchodilators are not only symptomatic treatments, they impact on future risk because A, they prevent exacerbation, and B, I believe that improving physical activity is something that has to do with individual risk. And this is why I believe that bronchodilators, by increasing activity, also impact on future risk. And as I said, this remains ultimately to be proven in a study that is designed to show an effect on all-cause mortality in these inactive or priorly inactive patients. Thank you very much.
Thank you, Dr. B, for this wonderful presentation. I will open the floor for questions. There are several people who are going to ask questions. I will allow myself, I have the right to start with the first question. The INSPIRE study that you alluded to, actually, when it looked at the tiotropium versus the combination therapy, it did show that there was no difference in the efficacy in terms of outcome. But in the rate of exacerbations, in those exacerbations that occurred in each arm, in the arm that actually was on tiotropium, those patients got better when they added steroids to their treatment of the exacerbation, and vice versa. In the other group, when they added a bronchodilator to their regimen, an antibiotic, they got better. So the question is to you, and I fully agree with the effect on hyperinflation, but you're saying that there is no role for inhaled corticosteroids in COPD?
No. There's definitely not. This is not my message. I wouldn't say you're not doing malpractice if you use ICS and COPD. I mean, guidelines recommend them at a certain stage. My question is, what's the best strategy? My main message is it's totally different from asthma. You can do proper, very efficacious therapy in COPD without using inhaled steroids. And my message is, if you consider all the different steps, your individual patient, what is the best strategy? I find from the evidence-based literature, I can't identify any outcome that is better off with the use of inhaled corticosteroid than with the approach to improve and maximize bronchodilation. So even those outcomes where we believe, now these are very closely linked to inflammation, exacerbation. Yes, there is an effect of ICS on exacerbation. There's no doubt. It's been clearly shown in some studies. However, is it better than another drug with a different mechanism that does not include inhaled corticosteroid? And obviously, in a direct comparator trial that was actually organized by the sponsor of ICS LABA, there is no difference. So my question is, why should you use two drugs twice daily if you can have the same with one drug? And the component there does not tackle any of the other important things we know in COPD. Hyperinflation, dyspnea, quality of life, and all that. So it's clear. It's not that I say there's no role of that, but the question is really what is the best strategy? And I'm a firm believer that you start with bronchodilator. If you don't get along with one bronchodilator, you add a different bronchodilator. And then maybe at that step, show me data, show me studies. Triple therapy, we don't have data. There's no evidence for triple therapy now, unless the Canadian study, which did not show a difference for whatever reasons between triple therapy and double therapy. Well, then you may be considering, if there's on top of LABA-LAMA still exacerbation occurring, you may consider where this could be an indication for ICS. But get away from the thinking, where start with ICS and LABA, where just because it works in asthma and we've always been doing so. It's different. Get away from that concept. We have different targets to tackle, and we need different strategies. That's my message.
Thank you. Dr. Alemi and then Dr. Waqid.
Yes, I have a question. I agree with your conclusion here. I mean,
Sorry.
Yes. I agree with the conclusion, except one thing that you mentioned, that it prevents exacerbation. LABA, ultra-LABA, or combination treatment, there are a lot of studies that mention that this kind of drugs reduce the rate of exacerbation or prevent the exacerbation. Exacerbation of COPD is related to viral illnesses, bacterial reactivation, or pollution or other factors. How come bronchodilator can prevent or can decrease the rate of exacerbation? It's not an immunomodulator, it's not antiviral, it's not antibacterial. How come we can say that it reduces the exacerbation?
Okay, before I answer that question, or try to answer that question, let me just give you, if you like, give your question back to you. Inhaled corticosteroids do not impact on viruses, they do not impact on bacteria, they do not even impact on inflammation. We know biopsy studies, there's not a lot of anti-inflammatory effect. They do not impact on symptoms, so why should inhaled corticosteroids, even if we showed that in clinical studies, why should they have an impact on exacerbation? The answer to this, we don't know. What about bronchodilators? Now, there also, again, we don't fully know the mechanism. We know that, of course, as exacerbation are very often driven by symptoms. And with long-acting bronchodilation, you alter the threshold of symptoms. So it may just be that you actually prevent the flare-up of certain symptoms. That's one theory. The other theory is if you reduce hyperinflation. We know at least from some, well, it's not human data, But we know that hyperinflation and the mechanical stretch in the peripheral airways actually further increases epithelial damage and inflammation. So it may be that by reducing mechanical stretch of hyperinflation with bronchodilators, you may get, if you like, an indirect anti-inflammatory effect. This is science, rocket science, never been proven in humans, but it's one of the theories we have. Otherwise, I agree. We don't know the exact mechanism why this happens, but unless, for the simple fact that we don't know for 50% of exacerbations, we don't know the cause of exacerbation. We don't even know whether this is exacerbation of COPD or exacerbation, as Leo Fabry would say, exacerbation of respiratory symptoms. Then it remains speculative. So first thing is really get a gold standard for a COPD exacerbation. Maybe a test tube. Put your finger in and then indicate, wow, this is COPD exacerbation. That would be great, biomarker. We don't have it. So we are uncertain with the definition, and this is why we are uncertain how to explain some of the drug effects that we see. That's my open answer to that. So I have to rely on the data. That's it. I don't know how. As Franz Beckenbauer said in Germany, in one of the famous commercials, you know Franz Beckenbauer, of course?
Yes.
Yeah? No? Yeah, sure you know. So he said in a very, very famous commercial, I don't know what, for a computer, something like that, I don't need to know how it works, I just must rely on that it works. So that's my answer to some of the data. Yeah.
So that's better to say that it make life of COPDers easier, but not it prevent exacerbation.
If you measure prospectively exacerbation, it prevents. Yeah?
There are data.
Yeah, it does.
Dr. Waked and Dr. Koniski.
Thank you very much. It was an excellent talk. I completely adhere with your explanation concerning prevention of exacerbation. And the theory is a very, very elegant one to explain how bronchodilator with the area under the curve with the long-acting were always bronchodilated, so it could prevent. I would like your comment on one, let's say, interesting explanation on maybe there are two types of exacerbation. The one which goes very rapidly and very suracute due to bacterial infection or viral infection, and where really the place of bronchodilator would be very interesting in preventing exacerbation. The other one would be the progressive exacerbation or worsening, where it might have a place for ICS. I would like your comment.
Yes, I mean, if we did some sub-analysis in the POET study, and the funny thing is, in fact, if you look at those patients, those exacerbations that required antibiotic treatment and those who required systemic steroids for whatever reasons, I mean, because the doctor decided based on whatever clinical grounds, there was no difference. It reduced the exacerbation requiring antibiotics and systemic steroid and the combination of both. So we're still puzzling whether this is by bronchodilation and indirect, if you like, maybe better clearing of airways or whatever, and being less prone to bacterial or viral infection. That's one answer. The second answer is, yes, of course, we know that there is quite a consistent correlation, frequency of exacerbation and progression of disease. Not in every patient, but there are patients that are progressors because of exacerbation. And of course, the assumption is if we prevent exacerbation, then we impact on the decline. There are some data now, post-hoc data, retrospective analysis, both from Uplift and also from Torch, that show that it's a bit different to what we thought before. Obviously, you need to start early, in early goal stages, goal 2. If you put them on treatment with long-acting bronchodilators early on, you may have an effect on the progression of the disease. But I would say this with large caution, because we used to think that for many times in history from post-hoc analysis, and it turned out not to be true in prospective clinical trials. But that would be, in fact, an idea and a nice concept to study.
Last questions, Dr. Koniski.
Going back to your conclusion regarding the characteristics of the patients, don't you think that this is very important, like phenotyping or typing your patients? And is there still a place for something that we used to call resistance to corticosteroids?
Yeah. I mean, the concept of phenotyping is it's very fashionable presently, be this in asthma or be this in COPD. It's got a lot to do with the difficulties to show in unselected patients for some new drugs to show effects. So this is what in former times we called it subgroup analysis. Now they call it phenotyping. And it's, as I said, it's very fashionable. The question really is, where will it bring us? Will we end up with 10, 15, or 20 different phenotypes, and whether this is of any use? 15 years ago, we tried to make a uniform diagnosis, COPD, to make it easier to communicate. And now we're just turning our back on that and say, well, it's not COPD at all. We know it's maybe 20 different diseases. It may be scientifically accurate, but is that really something that is going to change our treatment? I mean, definitely we have to look in all these studies whether there are certain responders to certain treatments. Unfortunately, we are far from really understanding good phenotypes. So we don't really have reliable phenotypes. We're talking about the phenotype of the frequent exacerbator. Honestly, if you look into the data, the Hearst study, Eclipse did not account for treatment intervention. If a patient had in the second year a different treatment than he had in the first year, it didn't account for that. We know that treatments have massive effect on exacerbation. It's not accounted for in Eclipse. And even those who had stable exacerbator phenotype were less than 50%. So 50% of patients have this phenotype now and the next one tomorrow. So my question is, if a phenotype is stable in only 50% of patients, is that really a phenotype? It's an open question. And the other one is chronic bronchitis and frequent exacerbators. I mean, this is something that's also very questionable. Is this a phenotype? It's a Daxas phenotype. The phenotype was created as a out of a post-hoc analysis of the phase 3 data of Daxas. So is that really something that it will bring us further, definitely. But is it something we can work with now, today? I think there's a lot of talk. It's very fashionable. But currently, I don't really see a use for clinical practice. The same guys that have 5 years before told you never to use the term pink puffer and blue bloater again, because this concept is not valid anymore. Well, these are the same guys, and now go out and talk about phenotypes in COPD. I mean, we already had this. It's all been done before. Pink puffer, blue bloater, that was phenotyping 30 years ago. So step back and wait for whether this is really a good concept we can work with.
Thank you very much. I would like to close this session. I thank Professor B for this wonderful presentation. We're already over time. Thank you so much.